This is Midwest Moxie, a show about our region's visionary entrepreneurs and the experiences that shape them. I'm your host, Kathleen Gallagher, Executive Director of Five Lakes Institute. Graham Colditz is an internationally recognized scientist who's written more than 1,000 research papers and created several award-winning models for predicting women's breast cancer risk. But it wasn't until a young biostatistician named Joy Jiang arrived at Washington University in St. Louis that the idea of a startup took hold. The two developed AI technology that analyzes subtle changes in mammograms over time and predicts a woman's 5-year risk for cancer. In 2024, Graham and Joy co-founded Prognosia to commercialize their software. A little more than a year later, Prognosia was acquired for an undisclosed price by Lunit, a South Korean company whose AI software helps doctors detect cancer. Graham and Joy, welcome to Midwest Moxie.
Thank you.
Graham, you're the person at WashU who hired Joy. What were you thinking when you hired her? Were you thinking startup?
Oh, no way. We were really looking for a statistician with the skills and energy to build sort of new statistical methods and models. Joy talked in the hiring interview of interest in prediction and dynamic prediction. And so I was like, well, we have breast, but she was working in brain disease and still hired her for the richness of her skills rather than for a specific project.
Joy, it was you who came up with the idea for doing a startup. How? Why?
Well, we had this conversation about, the ultimate goal of our research product is to get into clinic so that women and providers can use them, right? And what is the route of getting there? Because we've obviously both of us have done, many research projects that are widely used by researchers, but actually never got into clinics for patients to use. And we thought about it, and for a device like the AI tool, it's going to be a software as a medical device that needs regulatory approval, that needs significant amount of infrastructure building, which, both of them require investment, and therefore it requires an entity to hold it. So it was a logical way for us to sort of step into this world of startups, thinking that we can actually build this for its usability and commercialization potentials so that we can actually get this, to the market instead of just sitting as a research product.
Spoken like someone who's lived in Boston.
Thank you.
Life sciences startup, capital of the country, right? So, Joy, the traditional way of training AI models involves pre-specifying everything you want this model to do. There's a more modern way to do it that you were aware of. Tell us about that.
Sure. So previously, the way we think about training models is you would tell the model exactly what needs to be inputted. So for traditional breast cancer risk prediction models, we have to specify age, BMI, family history, et cetera, that are known to be inputted into a model to be able to train that specific model. So nowadays, in modern ages, we actually have much more data than we had before. And a lot of those data come from images, which contains millions of pixels that are available. So without specifying exactly what's being inputted into that specific model, we now can have a greater potential to incorporate all these high-dimensional pixel level data that would give us more information on the texture information of the breast, for example. So that actually makes the model a little bit more smarter, instead of you telling the model what to do, but the model actually also has its way to determine what's more informative and
thinks for itself in a way.
Yeah.
So Graham, you're well known around the world for developing some of these early models for detecting breast cancer risk. What were you thinking as the two of you put this together to use these images over time?
Great question, because you're right. More than 20 years of working at the risk factors, adding markers from DNA and so on, and never really getting a powerful prediction performance or finding a way to integrate that into, say, a mammography service where hundreds of women are screened every week, and you don't want to disrupt clinic, right? And so the appeal here was that the mammogram's already taken and sitting in the system, if you will. The radiologist will read the mammogram. It would be really cool if Joy could take those images and use the AI to make a summary of the risk that would then be presented to the radiologist. 5-year risk is what we focused on because there are guidelines that it ties to, but the point was more that this actually fits in the workflow instead of being another task for someone to complete a risk assessment. It was coming literally with the screening mammogram that the women were having.
And you guys had the advantage of a cohort of 10,000 women that starting in 2010 in St. Louis, you had the mammograms for all these women over time, right?
Right. When I was recruited to WashU, early on, I met with the head of the mammography service, and she basically said, Graham, you ran the nurses' health study. You know how to recruit and follow women. We're screening tens of thousands of women. Would you like to work with us and understand risk and improve our service? So that was an invitation too good to pass up. 25% of the women in the screening service, African American, some Asian women. So a much richer population than the nurses' health study had been, which was 97% white. And so that set us going to consent women for long-term follow-up, access to their breast tissue and the cancer outcomes. And we were maturing that data when Joy was recruited.
And just to be clear, because you had these images over time from the mammograms, you could go back and look and see changes that were happening before a diagnosis that helped inform looking at them going forward, right?
Right. The first project that Joy did actually looked at each breast separately, because one of our colleagues said, women don't get breast cancer in both breasts at the same time. Why aren't we looking separately at each breast to see the one that's going to get cancer surely is changing before the cancer's diagnosed, isn't it? It's like, well, that's a good question. Sure. So Joy, hey, how about we take this on and look at each breast and follow each breast over time? And that led to the first major publication that we did.
So you guys figured out how to use these images for better prediction. Great. But, so often in the medical world, you get a better prediction and then there's nothing you can do about it anyway. So how do you look at, is there something I can do if I get a prediction that I'm more susceptible to breast cancer?
Sure. And that's part of the beauty of how we've summarized the risk. There are national guidelines, Preventive Services Task Force, NCCN, the National Comprehensive Cancer Center Network, that literally lay out for women at different levels of risk of breast cancer strategies to lower risk, whether it's endocrine therapy, additional imaging because they're at such high risk. And so we actually calibrate and report the risk, above 3%, which makes you eligible by the recommendations from national bodies to have a discussion of the benefits of endocrine therapy to reduce your risk of breast cancer.
Joy, clearly it helped a lot to be working with Graham because he knew all this guidelines stuff and all the parameters, right?
For sure. I mean, part of model building is not just building the model numerically. It has to be sensible and it has to output the right information for the right user. And so I think this is why our team is super robust in a sense.
And we've got a breast imaging specialist with whom we meet regularly who can frame and interpret and say, if you did it this way or answered this question, it would help our service. So the interface, again, with the active radiologist reading mammograms all the time enriches the focus on getting answers that will be useful in clinic.
Neither of you wanted to leave your academic job. Obviously, you love working on this kind of stuff. How did you find a CEO for Prognosis?
So we work closely with the Office of Technology Management, the OTM office. And
at WashU.
At WashU, yeah. Mm-hmm. And we have a local venture group called the Biogenerator in St. Louis, where we actually found an entrepreneur in residence, Dave Smoller, who was a tremendous help to all the business side of things.
He's well known in St. Louis, one of the big life sciences entrepreneurs in St. Louis, right?
Correct.
So that was very helpful. You got this company going. You got acquired by a big company that's theoretically going to, deliver this to the world. What are the implications of your software as Lunit develops it? How might this change the way women approach mammograms?
So Lunit has a major share of market space in the US, in the mammography market. And in fact, WashU is one of their customers as well. We use Volpara so Volpara is part of Lunit now. We use Volpara for density estimation and also our risk pathway analysis. So because they already are in the market in this space, by partnering with them, our technology can get into the hands of patients and women and providers very, very fast. Right?
And what will it change? I would imagine, right now, there's kind of a general risk everyone's looking at. Will it calibrate, like which women should be treated differently, more finely than now?
Yes. So right now, the FDA says every woman with dense breasts should know she's got dense breasts. What should you do? And the guidelines say talk to your radiologist. If you can put dense breasts and your risk together, you can be offered additional imaging. If you don't have dense breasts, but you have risk above the 3% 5-year cut point, discussion about the risks and benefits of endocrine therapy that, in essence, block the estrogens and their impact on breast tissue and halve the risk of breast cancer. So there are definite steps to take to understand the risks and benefits of prevention strategies. And so this can be folded literally into the flow of every woman having her routine mammograms. And as additional mammograms accumulate over time, the potential is to bring the trajectory of change in the images into the prediction to further improve that stratification and identification of who's at the high risk and can benefit from more follow-up. We can dream down the road that the women in the lowest level of risk certainly can be reassured. Some may well only need the mammogram every 2 years. Potentially, it could be spaced out more. Obviously, some research needs to be done there to understand that better, but really get to tailor your personal screening frequency based on your risk.
Well, it's an amazing story and portends change in the way women experience mammograms. So thank you so much for sharing it with Midwest Moxie.
Thank you.
You can read more about today's guest by visiting wuwm.com. Don't forget, you can also listen to the show as a podcast if you'd like to take us on the go. Just search for Midwest Moxie, that's MOXIE, wherever you listen to your podcasts. I'm your host, Kathleen Gallagher. Midwest Moxie was created by executive producer Audrey Nowakowski and me. Today's episode was produced by Audrey Nowakowski and engineered by WUWM's Jason Reevy. Join us next Saturday afternoon at 2:30 to hear from more visionary Midwestern founders building innovative companies. That's right here on 89.7 WUWM, Milwaukee's NPR. Support for Midwest Moxie comes from Microsoft, whose efforts to drive technology development across the Midwest and beyond include its National TechSpark community engagement work, which started in Wisconsin, its role as co-founder of Titletown Tech in Green Bay, and its new AI co-innovation lab at University of Wisconsin-Milwaukee. More information is available at Microsoft.com. Support also comes from Quarles, a multidisciplinary AM Law 200 firm with approximately 550 attorneys who support large and small businesses, from Fortune 500 companies to startups and entrepreneurs across the country. More at Quarles.com.